Fox. I'm a haematologist from Nottingham in the UK, and it's a real pleasure to chair this session. And we've got two world-class speakers who've been involved in primary CNS lymphoma from the pathology side and also the clinical side for the last 2 decades or so. So there's no one better to speak to you in the first instance about the challenges in the diagnosis of primary CNS lymphoma and some biological insights that we've learned over the years. So Professor Ponzoni from the San Raffaele University in Milan, and we'll hear from you first. Thank you.
Good afternoon. Thank you so much, Chris, for introducing me. I would like to thank the HA organizing committee for inviting me. It's a pleasure to be here with you. I just offer our own experience of the diagnostic approach to this very peculiar kind of lymphomas. I think that we can split our presentation in 3 portions. First, we will introduce the classification of the major morphological abnormalities. Then we will switch to the biological achievements of these rare kinds of lymphomas. And then we will try to see whether we can apply these achievements by biological standpoint to the practical implication in the routine practice. So as you know, we have right now, hopefully not for the future, still 2 classifications. And they partially overlap in classifying these tumors. For instance, in the WHO, we know that PCNSL has been grouped together with primary vitreoretinal lymphomas in a category that has been called immune-privileged sites. It's curious to know what we mean for immunoprivilege, but we will see hopefully in the next year whether this term will be used or not. And the ICC regards as a separate entity from other DLBCL, the primary central nervous system lymphomas. From a histological standpoint, the diagnosis usually is not so difficult. We have a perivascular arrangement of these cells. These cells are large cells, are characterized by centroblastic or immunoblastic features. Of course, we discourage the use of corticosteroids before taking the biopsy because you may suffer from interpretation biases. Sometimes you get a lot of necrosis because of the corticosteroids, and sometimes you can have some sort of, not informative tissue. So please avoid corticosteroids for a while before taking the biopsy. And mutuating what we know from the gene expression profiling studies from systemic DLBCL. We know that the Hans algorithm was driven from the previous studies from Lustau groups in Nature back 2001, and we know there are so-called germinal center phenotype and non-germinal center phenotype. So these rules should be applied ideally just to systemic DLBCL. But if you want to apply this algorithm to the PCNSL, you will see that there is an increase or an unbalanced proportion of cases that do exhibit the non-germinal center phenotype. There are not so many prognostic features by histological standpoint in these tumors. Our group some years ago published a series of 100 cases in which we found that whenever you find out a sort of perivascular arrangement of T cells, this means that the prognosis seems a little bit better. This was not, supported by biological studies at that point, but I hope that after a few slides, there are some possible explanations for this arrangement of T cells around the vessels. Having said that, it is very important to not forget that when we deal with primary brain lymphomas, not each case is a DLBCL. There are very rare occurrences, but there are some cells that are primary tumors, or primary lymphomas of the brain that are characterized by different histology. Low-grade lymphomas like the marginal zone lymphomas in the meninges, or T-cell lymphomas, and even also anaplastic one. So it's better to avoid to confuse the term of primary brain lymphomas as a synonym of DLBCL. And last but not least, this category that regards primary vitreoretinal lymphomas is very important. Why is that? Because the diagnostic difficulty here for pathology is very high because first of all, we don't deal with histology anymore. We are cytological material. These cells are free-floating in some sort of uncomfortable environment because the heavy proteinaceous environment may cause some, the arrangement of the cells. The cells are bad preserved. They are not well preserved. and there is an administrator of non-neoplastic cells that may hamper or increase the diagnostic difficulties. You will apply flow cytometry. There are some biases in that, and there are also some biases in applying molecular biology because of the phenomenon of pseudoclonality. Some people, some authors, very authoritative authors, proposed also a sort of ratio between the IL-6 and IL-10 levels. But the differential diagnosis indeed is very important because there are some non-neoplastic disorders that may mimic these lymphomas, and for instance, the uveitis. Given that in the recent years, very important groups around the world were able to stratify in a supervised way the LBCL, irrespectively of their anatomical site of origin, and were able to provide, with this study from a Margaret Sheep group and together with the Lust-out groups, that there are some categories that can include preferentially some entities. And for instance, there is a group that is called, C5 subgroup or MCD group, in which you have many cases of PTNSL, and they carry many mutations that involve mostly MAD88 and CD79B. Now, this is the attitude of neoplastic cells in primary CNS lymphomas, and you can see by yourself that there are several pathways that are involved. And I wanted to draw your attention that there are some pathways that involve interleukin-1 receptor, toll-like receptor, JAK-STAT pathway, and BCR that have some downstream molecules that in these tumors are mutated. And they can confer a sort of molecular profile, if you want, that are very important to keep in mind also for confirmation or diagnostic confirmation, if you want. This is not an exhaustive slide, but it tells you how complex is the property of the neoplastic cells. Given that, we should not forget also the role played by the microenvironment. This is much more complex. We usually think about microenvironment and we refer to T cells, but T cells are just one part of the story. And just talking about T cells, right now we know that in PTNSL we recognize three different subtypes. One is the intratumoral T cells, one is the peritumoral T cells, and also the intratumoral but perivascular T cells. And these T cells are able to interact with B cells together with other microenvironmental components like endothelial cells, microglia, and macrophage, as well as the astrocytes. So each of these cell components is believed to play an active role in the pathogenesis of these lymphomas throughout the secretion of some cytokines, for instance. And why I'm telling you? Because if you come back to our previous observation, we saw this perivascular rim of reactive T lymphocytes. We better understood in the past years that this is not an incidental finding. So there are some chemokines and cytokines that are able to recruit these cells, not only the T cells, but also the neoplastic B cells. They act like chemoattractant. And the two particular molecules are present are 6CL9 and 6CL12. And these cells are produced by macrophages and by pericytes around the vessels. Let me stress also that macrophages are different from microglia, so this is another important cell player in this tumor that we have to keep in mind in comparison to systemic DLBCL. And this led to produce a very nice paper that I quote with great pleasure. Dr. Hussein, Professor Hussein is one of the co-authors here, in which grouping some molecular findings together with the anatomical sites and neuroimaging, some subgroups with different prognosis has been proposed. Now, the challenge is to reproduce these studies on a large scale. And why we made this background information? Because we have to find out whether some of these molecules would be instrumental for us to translate them in diagnostic environment. And these guidelines have been recently published, including mostly made by Dr. Ferreri and Dr. Calimeri's work, just show us that the stereotactic biopsy still remains the gold standard approach. This has to be kept in mind very clearly. However, we have to recognize that in some instances, the stereotactic biopsies could not be taken for different reasons. So we have to find out an alternative diagnostic approach. And whenever this histology is not available, we have to move to cytology, which has a low sensitivity, and to introduce the use of so-called biomarker. Some years ago, our group carried out a prospective study, including the use of MAD mutation grouped with high interleukin-10 levels. Why was that? Because we analyzed the literature data and we found that these were the most promising markers. At that time, we were referring just to the L265 variant, not all the mutation of the gene. And this was coupled with the levels of interleukin-10 in the CSF of this patient. So at that time, we analyzed more than 150 control cases that were recruiting, inflammatory disorders of the CNS and other neurodegenerative disorders. At diagnosis alone, the mutation is able to catch up 70% of cases with a specificity of 99%. Whenever you combine this approach with the evaluation of the levels of interleukin-10, sensitivity much increases to 94%, and specificity is more or less the same. Now, why is it important to group together these markers? Because if you analyze them individually, also in the control groups, we saw some cases that were positive, so they carry MAD88 mutation. So per se, the mutation was not pathognomonic for the presence of the lymphoma. And the important thing, none of controls shared both the combination of MAD88 mutation as well as the increased interleukin-10 levels. So on these grounds, we include routinely these markers in CSF evaluation of our patient, behind the fact that we still perform, fortunately enough for us pathologists, the biopsies. So when it could be useful to think about this diagnostic alternative approach, whenever, as I mentioned to you, there are some lesions that are not reachable by the most experienced and smart neurosurgeons. I am referring to very, very deeply seated lesion, or the, in the first, near the cerebellum or whatever. In these cases, an approach has been attempted, and some results are very, supporting the fact that these two markers may be able to recognize lymphomas. Notwithstanding this, we exploited a diagnostic panel that we use sometimes for systemic DLBCL that is able to catch a series of genes that are mutated. And you can see within this panel that many of the genes that we recognize that are associated with the PCNSL are present. So our routine work is able to give us an answer in 4 days, 4 working days, in which upon a DNA extraction you catch the final results. So on these grounds, these are preliminary results. This has been applied to CSF and to vitreoretinal fluid. We are able to recognize different kinds of mutation. Pay attention, please, to the fact that also the classical MAD88 is accomplished by other alternative mutation that you cannot catch just by real time. So, summing up this approach, this routinely employed panel will be able to offer a rapid detection of the presence of mutations. Very importantly, this panel is set up commercially for paraffin-embedded material, so you require at least 10 to 20 nanograms of DNA. But in our hands, we are able, by experience, to pick up also small samples with a very low amount of nanograms. In this sense, we can try to apply this approach also not to histopathological specimen, but also to liquids and fluids whenever you have a small amount of cells there. In fact, also we are able to document that there was a concordance rate between the tissue-based approach of RT-PCR together with this NGS panel. Therefore, we are quite comfortable in stating that also the liquids and the fluids may be, studied with this approach. And we have already implemented our NGS panel in this sense. So, summing up, given that we cannot replace the biopsy right now to obtain a diagnosis of PTNSL, which are the diagnostic advantages that may be able to use the CSF detection of this mutation? First of all, we can address the indication to biopsy. In a brain mass in which you have an increase of these two markers, it is unlikely that you have something which is not related to lymphomas. So when you suspect lymphomas, you should avoid the tumor resection, as you know, because the neurosurgeon, instead of removing the lesion, may just perform a stereotactic biopsy. And this means that you have a great advantage in terms of morbidity for the patients. You should not wait for the response for corticosteroids, response, stating that a lesion that is responding to corticosteroids is necessarily a lymphoma, which is not the case. And in some neuroradiological dilemmas in which our colleagues are not able to stratify properly PCNSL from other mimicking lesions, this approach will be very advantageous. There are also advantages from a clinical standpoint. So you have the chance to perform a more prompt specific therapy. You can avoid the use of extended use of corticosteroids. Neurological symptoms are much more improved, and you can save also the cognitive function of the patients. And this impact on the overall survival and the disease progression-free survival. So in other words, the quality of life of the patient is improved. And also by socioeconomical standpoint, you avoid a lot of expenses with this approach. So let me just remind you that even beyond these advantages, not each PCNS cells can be detected on the CSF, first of all. Secondly, not each PCNS cells does carry those mutations that I showed you earlier. 10% of cases do have a sort of germinal center approach, germinal center molecular profile. Not each B cell in the CSF is a PCNS cell. And not each lymphoma in the CNS is a B cell lymphoma. So, and finally, if you want to separate a primary CNS from a secondary involvement of the CNS by the LBCL, these mutations are not able to stratify. There are some important implications about the use of a panel of genes. This is the German experience of our friend Frautkopf and Leticia Quintina Martinez that applied a panel to the vitreoretinal fluid. We are doing the same, and also we are able to test this mutation not on the vitreoretinal fluid but on the aqueous tumor, which is in the anterior chamber of the eye, which is even less invasive. I just stop here. I just want to thank all the friends and collaborators that allowed me to be here. Without them, I would not be able to tell you all these things, and I thank you for your attention.
Thank you very much, Murillo. Well, an excellent overview and some really interesting biological insights. Happy to take questions, and maybe I'll just kick off with the first one. My practice is still to biopsy patients, image-guided stereotactic biopsies wherever possible. At least that's what my surgeons do rather than myself. But do you think we're close to a different approach, given the specificity of MYD88? Could we first approach the CSF before moving on to a biopsy? All biopsies carry some morbidity and occasionally mortality.
Yes, of course, taking a biopsy, even if it is not so invasive like the stereotactics, carries intrinsic risks. And I'm sure that everybody wants to avoid this risk. We have to make a balance between to avoid this risk and to not performing well from a diagnostic standpoint. So on the ground that I mentioned, MYD88 are associated to these lymphomas, but they are not the only one. That's why on one hand we have improving the group of mutation that we're going to study. On the other hand, we have to be aware that even if you got this mutation, this does not imply that these lymphomas are there. So the final answer is that we are close but not so close.
Thank you. Another question perhaps on the biology. You talked a little about the role of T cells and the different populations of T cells, both within the tumor and within the vascular space. There's also some increasing recent data on the role of macrophages within the tumor, and it seems like there's this axis of tumor cell, T cell, and macrophage. Any insights or comments on the macrophage?
I did not mention that because of the sake of time, but I'm very glad to discuss them because, as we know, there are three classes of macrophages. So what? One it is M1, one it is M2, one it is neither 1 or 2, so nobody knows what they are. And there are some protumoral macrophages that are close to the tumor, some other that are within the tumor, and some other in which you don't know exactly what they are, and because of this, nobody is able to understand their role. But for sure, there is a different subset from the classical ones. So the dichotomy between M1 and 2 is very fashioned, but I'm not sure that it represents the real life.
So we seem to be delineating these different immune signatures driven by macrophage and T cell populations, and we need to learn a little more.
Yes, the relationship is going to be investigated. There are very preliminary results that we should keep confidential because we need to understand better.
Sure, understood.
And let me also comment that one important issue is that we can, given the peculiarity of this kind of material, and even that we receive very small amounts of material, nowadays we have a technical achievement that allow us pathologists to better understand the story because we have digital spatial profiling applied with the multiplexing approach. So I'm quite confident that we will understand a little bit more in the future about that.
That's important that you can now do increasingly more with less tissue, whereas that has been a barrier historically with primary CNS biopsies, so that's really useful. Okay, we have some questions at microphone 2.
Thank you very much for the interesting talk. If I recall correctly, you had a lymphoma panel for the DNA analysis of 60 genes, but in your oncoprint we saw some samples without any mutations in any of the genes that you profiled in your figure. But could you speculate on what the molecular or the reason for the lymphoma is if there are no of the mutations that you have in the panel?
Thank you for the question. This is another way to be enthusiastic about the approach by molecular standpoint, but we have to be aware of the limits. And the limits mean that we don't know yet fully the story. And this is a sort of compromise, exploiting a commercially available panel together with our needings. But life is more complicated, so we need to improve the knowledge about the biology of this tumor. We are just on the tip of the iceberg, in my opinion. That's why we can build up a more structured ad hoc panel, but right now it's not possible.
Okay, thank you.
You're welcome.
Also from me, thank you for an excellent talk and very practically relevant. The question is, does the location of the CNS tumor affect the sensitivity of liquor biopsies? Does more DNA leak out into the spinal fluid depending on where it is? Because the deep lesions are the ones that the surgeons don't want to biopsy, often, frequently.
Yes, thank you for underlying this phenomenon. As far as I know, there are not so much differences about the anatomical location. Whenever you are successful to obtain the material, which actually it happens in the vast majority of cases, let me stress that one. I'm talking about more than 95% of the situation. But there are bona fide some cases in which neurosurgeons tell you, listen, I cannot do that. And in those cases, I think that exploiting this attitude, in the editorial written by Dr. Calimeri that I quoted, there were some cases that at the beginning were not able to undergo biopsies. And we knew that they carried MD88 and interleukin-10 levels increased. And on these grounds, they decided to treat the patient. And the answer was like the usual response of the patient. But, you know, it's better to have a sort of formal proof that it is a lymphoma, not only by molecular standpoint.
Prof, thank you for your excellent and inspiring talk. Can I ask about the T cells? What is it? You mentioned about perivascular, intratumoral, and peritumoral T cells. Are they tumor-specific T cells? Do they express PD-1? Because some time ago, actually, there is some indication that anti-PD-1 antibody is actually effective in primary CNS lymphoma. And actually, are these three components of T cell, are they the same?
Okay, thank you for the question. I think that it is very nice to see that there are different populations. We know that there are some coexisting different populations. There is not a case in which is built up just by a T cell subset or other ones. They coexist. And we have to understand where do they coexist. That is the challenge right now. So we can do that nowadays because we can couple the molecular with the morphological grounds on these new methods that are coming up. And I hope to be more specific in answering your question in the next future. But right now it's difficult to state that they relegate in certain areas on whatever. My personal view is that I'm expecting to see an admixture of these cells depending also to the phase of the disease, which is another situation that we have to correlate with our clinician to know exactly when the biopsy has been taken from the onset of symptoms, for instance. Because I'm quite confident that we will reach some important information. We will gain some important information about that.
Thank you so much.
You're welcome.
Okay. Over here.
Sorry.
Okay, thank you. Regarding the MyD88 and the CSF and the IL-10, how do you differentiate between that and Bing-Neill syndrome, primary CNS and Bing-Neill?
Yes, no. You know, your question is very good, but you know that Bing-Neill comes from a pre-existing lymphoplasmacytic lymphomas in most instances. That is a trouble to understand whether MD88 comes from a previous lymphoplasmacytic lymphomas. But this study has been taken just on primary CNS lymphomas. So we cannot rule out. To tell you the truth, some cases, we reviewed the bone marrow biopsies of all these patients to be sure that they were. And as far as I recall, no cases were associated with Bing-Neill syndrome. Different is the story that this patient may carry some monoclonal component in the peripheral, in the serum. This is a different story, IgM or not. But this does not mean that the patient has an underlying lymphoplasmacytic lymphomas.
Yeah, we have a mystery case right now at our institution, and the bone marrow has LPL in it. Well, we think this is LPL, and we can't biopsy the brain. So I'm not sure if this is like, is there a difference in the transform? Like, can it transform into a large cell lymphoma with the MyD88? And how would you know the difference between Bing-Neill and...
Well, the ideal situation will be that your CNS DLBCL has a different MAD mutation in comparison to the L26 in the bone marrow, but this is very theoretical. So I acknowledge that these situations are present in the real life, but this study has been carried out, ruling out deliberately the secondary involvement. Okay.
Probably just to add to that point, the other factors, the clinical and radiological factors would be important. If you've got homogeneously enhancing mass with a short clinical history, it's strongly suggestive of transformation, whereas Bing-Neill would be more leptomeningeal and a different history. So I think it's the whole picture, I guess.
Okay.
Great, okay, I think we'll move on. Thank you very much, Maria. It's now a pleasure to introduce Dr. Carole Soussaint from Paris, and Carole will be too modest to say that she was one of the pioneers of high-dose therapy, initially for relapsed and refractory primary CNS lymphoma, and then more recently, of course, established as first-line consolidation. So she's the perfect person to give us a review and update on where we are in this condition.
Thank you, Chris, and I thank the organizer for inviting me to this meeting. So I present the more basic stuff than Aurelio. Here are my disclosures. So my objectives are to first begin by summarizing the key milestones that have shaped current practice, and then discuss the most clinically relevant updates that are likely to change practices in first-line and relapse care. I will present also recent data on immunotherapies in CNS lymphomas. PCNSL remains clinically challenging. It's, as you know, rare and aggressive, confined within the CNS with the very specific microenvironment, and requires specific specialized diagnostic and response assessment. It is particularly very important to closely assess the CSF and the intraocular compartments in addition to the brain MRI at diagnosis, but also during treatment. And incidence increase with age, so many patients present comorbidities. And we also always have to keep in mind that the balance between effectiveness and feasibility of the treatment. Prognosis remains poor in the overall population, as illustrated by the left side of the slide, coming from a series in real world of more than 3,000 patients registered in our national database. But prognosis also is influenced by age and therapeutic management. The analysis of the first 1,000 patients of this database, and published a few years ago, showed a significantly different outcome between younger and older patients, mainly due to the lack of consolidation at that time in patients over 60 years of age. So high-dose methotrexate has been shown for more than 2 decades ago to be a key chemotherapeutic agent for PCNSL, but until recently we lacked new molecules for this disease and didn't really know how to improve the outcome of the induction phase of the treatment. One of the first questions was whether adding rituximab will improve outcomes. The role of rituximab is actually still debated, but in a meta-analysis that including a prospective phase 3 study by the OVON group and additional retrospective cohorts, the addition of rituximab was associated with a better outcome. However, the benefit of rituximab is absolutely not as dramatic as seen in systemic DLBCL. And in practice, actually, rituximab remains widely used and is part of the treatment options, even though it is not mandatory according to European guidelines. Dosage and administration schedule vary by country, and higher doses are usually used in the US. Various combinations of CNS-directed drugs are used with methotrexate. Here I listed the main induction regimens. Methotrexate is combined with either BCNU, procarbazine, VP16, or with thiotip and RSE in the matrix regimen. There is no international agreement regarding the standard induction chemotherapy. Some countries preferentially use the matrix regimen with the combination of rituximab, methotrexate, thiotip, and RSE, when others use the RMPV regimen with rituximab, methotrexate, procarbazine, and the vincristine tends to be omitted. When we look at the CR rate at the end of induction, focusing on the studies with a larger number of patients, results appear similar between the different regimens, although there have been no comparative studies between these regimens. And in the absence of comparative studies between the different induction regimens, the European guidelines recommended, by consensus, the use of at least high-dose methotrexate combined with an alkylator agent. A more recent approach consists of adding a target agent to high-dose methotrexate-based regimen, such as BTK inhibition, in 2 phase 2 studies, with ibrutinib added to either methotrexate and temozolomide or to RMPV. A very high CR rate was obtained, with encouraging 2 years PFS of 57 and 84%. It should be noted that in the second study by Schaff and colleagues, 9 patients out of 30 were referred and included in the study after receiving methotrexate and showing sensitivity to methotrexate, which suggests a slight selection of patients. Our group conducted a randomized phase 2 study to assess the benefit of adding ibrutinib or lenalidomide to the RMPV induction phase in patients up to 65 years of age. Responder patients then received a consolidation with RRC and a thiotypa-based autologous stem cell transplantation. The results were presented at the last ASH meetings. Very briefly, 92 patients with DLBCL, PCNSL were enrolled and equally distributed between the 2 arms. I'll go straight to the main results. In the LENA arm, we observed 86% of CR, 5% of PR for an overall response rate of 91%. And in the ibrutinib arm, the CR rate was 82%, PR rate 11% for an overall response rate of 96%. And we were very pleased to observe that a high proportion of patients, 77% in the LENA arm and 87% in the ibrutinib arm, were able to proceed to the transplant. And with a median follow-up of 22 months at the time of the analysis, 18 months PFS was 71 in the Ibru arm and 70% in the 70% in the LENA arm and 90% in the ibrutinib arm, and 18 months overall survival was approximately 90% in both arms. Well, so far, the consolidation remains an important phase of the treatment to reduce the risk of the relapse. What used to be the conventional whole brain irradiation, delivering 36 to 40 gray, should no longer be used as a consolidation treatment, to my opinion, due to the high risk of severe radiotherapy-related neurotoxicity. Age-adjusted thiotypa-based transplant is nowadays widely accepted as a standard consolidation in eligible patients, and they might also have a place for reduced dose radiotherapy. The first studies that challenged what was considered conventional consolidation, or whole brain irradiation, were the PRECI and the ALG32 trials. In this study, the experimental consolidation was a thiotypa-based transplant in first-line treatment, and both studies showed that affected patients affected by cognitive decline had received the irradiation, whereas the cognitive functions were preserved after transplant. In addition, in our group, in our study, in an exploratory analysis post-consolidation, we observed less relapse after transplant. Finally, the German phase 3 study comparing transplant versus conventional consolidation with 2 cycles of high-dose ifosfamide-based chemotherapy showed significantly better OS, overall survival, in the transplant group. This study was presented at the ASH meeting a few years ago, and we are waiting for the publication of this major study. The consolidation by transplant can be extended to selected fit patients over 65 with a less intensive conditioning regimen, as shown by the MARTA study presented by Elizabeth Schorb and colleagues. And consolidation with reduced dose of radiotherapy, reduced to 23.4 gray, tested in a randomized study with a non-consolidation arm, remains of interest in reducing the risk of relapse with a favorable neurotoxicity profile, although the safety of this approach in elderly patients is not clearly shown. And again, in the European guideline, by consensus, we kept the principle of a consolidation by either age-tailored transplant in eligible patients or whole brain irradiation. In France, we really recommend avoiding irradiation after age 60, whatever the dose. And in the real world experience, the outcome of responder patients who receive transplant consolidation in first-line treatment is very favorable for this population, as illustrated in the upper curves, the blue curves, with 5 years OS and 5 years PFS of 80% and 74% respectively. For older patients ineligible for transplant, maintenance approaches are under investigation. Retrospective studies showed no impact on PFS of rituximab maintenance and the possible role of maintenance by high-dose methotrexate. The maintenance with ibrutinib resulted in encouraging 2-year PFS of 75% in a single phase 2 study on 20 patients. And several prospective studies are ongoing. These studies assess the role of either rituximab, methotrexate, temozolomide versus observation, lenalidomide, procarbazine, nivolumab, or ibrutinib. The results of the study are still pending, which does not yet allow the formulation of robust recommendation. And therefore, the current European guidelines regarding maintenance in patients not eligible for transplant are quite inclusive. Wait and watch or maintenance with oral agent may be considered, and radiotherapy is still used in some countries. We move to relapse, because about 1/3 to 1/2 of patients develop relapse or refractory disease, and there is still no standard salvage regimen. Options include high-dose methotrexate rechallenge and other chemotherapy based on high-dose Ara-C or high-dose ifosfamide. Target agents, particularly IBTK and IMiDs, showed meaningful overall response rate in prospective phase 2 studies. However, duration of response are short without effective subsequent consolidation, which is highly recommended in eligible patients. But new and exciting avenues are emerging. A critical area is drug delivery across the blood-brain barrier and beyond older approach, such as osmotic disruption of the blood-brain barrier. A recent strategy consists of vessel target molecules delivery, such as TNF-alpha, combined with a peptide targeting the CNS vessels to improve availability in the CNS of drugs, such as the SHOP regimen, otherwise not penetrating CNS. Clinical data are encouraging, although preliminary. Regarding checkpoint inhibitors, first results were very disappointing with nivolumab single agent. Early data show measurable activity with pembrolizumab, but response rates in unselected population are modest. Several ongoing studies are evaluating checkpoint inhibitors in PCNSL, either with different drug combinations or at different stage of treatment, which could help to better define their place in the disease and maybe considering the biology of the disease will help to know what a subgroup of patients will benefit from these drugs. CAR T-cell, of course, therapy is becoming an exciting field. The updated experience of the French group has been recently published. The results of a series of 78 PCNSL treated with CAR T-cells are reported. CRS and ICANS were consistent with CAR T class effects. Most of the patients received a bridging therapy. Overall response rate after CAR T cells was 80%, including 60% of CR. And with a median follow-up of 20 months, 12 months PFS was 49% in the whole cohort and 61% in patients who achieve CR or PR after bridging therapy before CAR-T. CAR-T studies are ongoing across different clinical contexts, including relapse disease, specific delivery approaches such as intraventricular administration, and first-line strategies in transplant-ineligible patients. Finally, bispecific antibodies are emerging as another immunotherapy option in CNS lymphoma. The key questions were whether they can overcome CNS microenvironment barriers, which is always a big concern, especially with large antibodies, and deliver clinically meaningful activity with manageable toxicity. Glofitamab was detected in the CSF of 4 patients with secondary CNSL and at a concentration that could induce T cell cytotoxicity and T cell activation, as shown in the study by Godfrey and colleagues. We know now that the CNS is not completely immune isolated and that there is actually active interaction with the immune system. And now clinical data are available with bispecific antibodies, mainly in secondary CNS lymphoma, but they might be extended for primary CNS lymphoma. In a small retrospective cohort of 7 patients with secondary CNS lymphoma, Glofit monotherapy induced 3 CR and 3 PR with only low-grade CRS and ICANS in 3 and 1 patients respectively, and a duration of response of 12 months. My colleague Adrien Gilbert presented at the last ASH meeting the data of a retrospective larger study involving patients with active CNS lymphoma treated with bispecific antibodies. 53 adult patients were included in the study. All the patients had received a full flat dose of bispecific antibody, and most of the patients had a secondary CNS lymphoma. 4 patients had a primary CNS lymphoma. Median age was 59 years old. It was a heavily pretreated population with a median of 3 prior lines of treatment, including prior transplant in 11 patients and prior CAR-T cells in 25 patients. At start of the bispecific antibody, 22 patients had isolated CNS relapse and 30 patients had a synchronous CNS and systemic relapse. 34 patients received epcoritamab and 19 received glofitamab, which was administered alone in approximately a quarter of patients. 40 patients had a combination with another therapy. The most frequent concomitant treatment was an IMiD and less frequently an BTK inhibitor. Overall, the safety profile was quite manageable, even in this fragile population. 45% of patients developed all-grade cytokine release syndrome, and 22% of patients all-grade of neurotoxicity, and grade 3 or 4 CRS and ICANS affected less than 10% of patients. The overall response rate was 56% and was better when the bispecific antibody was combined with an IMiD and with an IMiD plus IBTK, reaching an overall response rate of 80% in the triple combination. And patients who achieve a complete response had a median PFS of 16 months, with only 3 progression events in this group. Patients who achieve PR had a PFS of only 4 months. And the role of bispecific antibodies will be better assessed in primary CNS lymphoma by the ongoing studies such as the eREVRI study designed specifically for relapse or refractory PCNSL, and in which epcoritamab is combined with rituximab and lenalidomide, and also with 2 phase 1b studies with either glofitamab monotherapy or the combination of epcoritamab with ibrutinib in primary and secondary disease. And back to basics, it is very important to closely follow up the patients during the treatment with MRI every 2 months during the treatment without omitting to assess the CSF and DI if initially involved. And after treatment, the international group recommend a follow-up imaging every 3 months for the first 2 years, and then every 6 months for 3 years, and then annually, especially in patients eligible for salvage treatment at relapse. Approximately 20% of relapse are asymptomatic. The ophthalmologic examination should also be repeated on an annual basis if not involved initially, and more often if initially involved. And neurocognitive function should also be assessed ideally on an annual basis, since late neurotoxicity of treatment can occur, and they are not well known with the more recent treatments. And we can discuss the treatment of PCNSL without raising the issue of response assessment and biomarkers. Response assessment is still relying on MRI, which is suboptimal, and so far we lack criteria for defining stringent CR. Various biomarkers promising are complementary tools to neuroimaging, such as CCL19 expression in the tumor and tumor microenvironment, level of IL-10 in the CSF, and ctDNA in the plasma and the CSF, both at diagnosis and during treatment. And before I conclude, I'd like to show you a partial optimistic slide. We looked, these are not published and they are very preliminary results, but we look in our database to the outcome of patients in 2 distinct eras. And the change in practice with an increasing number of intensive treatment and the use of target therapies seem to result in a shift with an improved outcome of patients up to 75 years old in the more recent era, starting from 2022. Unfortunately, no improvement is still observed in patients over 75 years old. So in conclusion, I think we can start to be optimistic with very promising new approaches. High-dose methotrexate remains the backbone, but target induction approaches are expanding our options, although this needs to be confirmed in larger comparative studies, ideally with a control arm. Intensive consolidation improve outcome in eligible patients. PCNSL remains still challenging, especially in older patients not eligible for transplant. The role of maintenance therapy is promising but still requires robust data. CAR T-cell therapy and bispecific antibodies represent promising approaches that will probably challenge the current ones. And because PCNSL are biologically heterogeneous, tailored strategies have to be designed. Studies on various biomarkers are under investigation to improve baseline risk stratification and response assessment. And I thank you for your attention. A special thank to my colleague in the National LOC Network and to the European and international group for the interesting and constructive interaction around PCNSL. Thank you.
Carol, thank you very much for a fantastic overview of now what is a lot of data in primary CNS lymphoma. So we have just 5 minutes for questions. If you're leaving, please do leave, but leave quietly so we can take the questions. There are a couple of questions online, but I think I'll take the ones in the room first, since there's a queue at microphone 2.
Professor, I'm James Chin from Hong Kong. Can I ask a question about, you brought us to the forefront of immunotherapy in primary CNS lymphoma. So can I ask, in the CAR T-cell trial, it seems that CNS toxicity is at 23%, or I'm not sure what is a grade 3 or any grade CAR T in primary, yeah, so the CNS toxicity is quite frequent. So what about bispecific? Do they have a much lower rate of CNS toxicity?
It's hard to compare because the series are still low, but it seems lower with bispecific than with CAR T-cells. The icons.
In the conditioning regimen, you mentioned about Valtipa plus Bilsai and Valtipa with BCNU. Do you think thiotepa plus BCNU has got any edge because as BCNU can penetrate to the CNS together with thiotepa, or do you think they're just the same in terms of conditioning for ASCT?
Oh, sorry. The thiotepa busulfan versus thiotepa BCNU?
Yeah.
Well, there are two retrospective studies on a large registry, and they showed that for sure thiotepa-based are better than BEAM regimen, and then it seems that thiotepa BCNU was a little bit, thiotepa plus busulfan was a little bit better than thiotepa BCNU. But thiotepa BCNU has the advantage to be less toxic and doable in elderly patients.
Hi, thank you. You show like a very strong results on consolidation in primary vitro in primary CNS lymphoma. But what do you think about the consolidation in primary vitreoretinal lymphoma? If we must proceed to autotransplant or not?
Thank you for the question. That's not easy answer. First, it is very difficult to assess the response, even more difficult in the PVRL than in the primary CNS lymphoma, because we only have the clinical aspect. So we must trust the ophthalmologist. But we are also helped with the IL-10 level in the anterior chamber. So far, we recommend, I don't know if it's, I don't know the outcome exactly, but we recommend when we reach a complete response, assess both by the clinical examination and with the IL-10 level in the anterior chamber. We recommend to consolidate with radiotherapy of both eyes, because in our previous experience with only methotrexate-based chemotherapy, we observed many intraocular relapses. But any time we have a DOP, the response is not complete, we'll go for salvage treatment and autologous stem cell. But we don't do a very first line in complete responder.
Thank you.
Hi, thank you for this nice presentation. I am Bedrettin from Turkey. I have a short case to ask, I must ask in this presentation. A 68 years old male patient presented with loss of vision in both eyes and diagnosed with intravitreal lymphoma, non-germinal center diffuse large B-cell lymphoma in both eyes, and staging with PET-CT, orbital MRI, brain MRI, and LP showed no involvement anywhere else. And over a month treated with both eyes intraorbital methotrexate, but he lost vision in his right eye and almost lost in his left eye. I have access to methotrexate, thiotepa, temozolomide, ibrutinib, and glofitamab, no access to CAR-T, and I don't know what to do in this case.
Well, it's a sad case because he lost the vision, so it's probably irreversible. In that case, 68, we would have started maybe by methotrexate, and if there is a risk of vision loss, we would have added, like you did, the intravitreal methotrexate. And now that he has still active disease, you still want to treat it because the risk, he won't recover, unfortunately, the vision, but it can relapse in the brain, and that will impact the prognosis. So probably with second-line treatment, either with ifosfamide-based chemotherapy and then autologous stem cell transplantation.
Thank you. Okay, final question from microphone 2, and then we'll close. Thank you.
Thank you. Does your induction regimen choice affect your conditioning regimen choice, especially for thiotepa?
No.
So you use again thiotepa for conditioning regimen?
In France, we don't use the matrix regimen. We use the RMPV. But I know that for centers who use the matrix regimen, they still use the thiotepa-based conditioning regimen. The doses are completely different.
Yeah. Thank you.
Okay, thank you. I'd like to close the session by thanking our speakers again. So a round of applause for Dr. Carol Hussein and Murillo Perrondoni.